The patient is already unconscious, not from anesthesia, from electricity. 2 paddles against the temples, a brief current, and the body convulsed and went still. It took under a minute. The instrument on the tray is not a scalpel. It is not a drill. It is, in every meaningful physical sense, an ice pick. The procedure will take about 10 minutes. No surgical team, no sterile field in the formal sense. 1 man, 2 tools, and a brain. He places the instrument at the inner corner of the eye socket. He doesn't cut, he taps. The point passes through the thin bone of the orbital plate and enters the frontal lobe of the brain. He moves the handle in a specific arc, side to side, severing fibers. Then he withdraws it, crosses to the other eye, and does it again. Walter Jackson Freeman II was born in 1895 into a family with a particular relationship to medicine. His grandfather was William Williams Keene, one of the most celebrated surgeons in American history, the man who secretly operated on President Grover Cleveland. Medicine was not just a profession in the Freeman family, it was a dynasty. Freeman graduated from the University of Pennsylvania School of Medicine, completed postgraduate training in neurology, and joined the faculty at George Washington University. He was, by any measure, a serious scientist. He published, he lectured, he ran a neurology department. But his degree was in neurology, the study of the nervous system, not surgery. The distinction matters enormously. A neurologist diagnoses, a surgeon operates. Freeman would spend his career pretending the line didn't exist. In 1935, a Portuguese neurologist named Egas Moniz presented findings at a conference in London. His claim that severing connections in the frontal lobe could relieve the symptoms of severe psychiatric illness. He called it a leucotomy. The procedure required drilling into the skull. It was experimental, controversial, and performed on a tiny sample of patients. Freeman read the reports. He was transfixed. Freeman partnered with a neurosurgeon named James Watts. Together, they performed the first American lobotomy in 1936. The method still involved drilling through the skull. Watts operated. Freeman stood at his side. But Freeman was impatient with complexity, with surgeons, with the whole structure of the operating room. That reminded him every time that he was not actually qualified to be there. In 1946, Freeman introduced a new technique, one he had developed in his own basement, testing the instrument on cadavers. No drilling, no surgical team, no need for a surgeon at all. He called it the transorbital lobotomy. His partner, James Watts, the actual surgeon, was appalled. He refused to participate. The partnership dissolved. Freeman took that as a signal to accelerate. The transorbital lobotomy required no operating room. That was the point. Freeman designed it to be performed anywhere, a clinic, a state hospital ward, eventually and infamously, a room in whatever facility would have him. The patient was first rendered unconscious through electroconvulsive shock, a jolt of electricity that caused a seizure and produced a brief period of unconsciousness. Not general anesthesia, unconsciousness induced by seizing. That was the preparation. The instrument, Freeman called it a leucotome, though it was functionally identical to an ice pick, was positioned at the inner corner of the upper eyelid. A mallet was used to drive it through the orbital plate, the thin sheet of bone separating the eye socket from the brain. This bone is fragile. It breaks at roughly the force required to crack an eggshell. The instrument entered the frontal lobe. Freeman would then rotate it in a specific arc, approximately 15 degrees to either side, severing the white matter fibers connecting the frontal lobe to the thalamus. He would withdraw it, move to the other socket, and repeat. 10 minutes. He timed himself. He was proud of the efficiency. In the late 1940s and into the 1950s, Freeman began what he called his road trips, loading his equipment into a vehicle he christened the Lobotomobile, and driving across the United States to state psychiatric institutions. At some facilities, He operated on dozens of patients in a single day. He photographed himself performing the procedures. He photographed the patients before and after. He kept meticulous records. He considered this science. One patient he did not meet on a road trip. She came to him through a different kind of referral. In the autumn of 1941, Rosemary Kennedy was 23 years old, the eldest daughter of Joseph Kennedy, one of the most powerful men in America. Rosemary had a mild intellectual disability, and as she entered adulthood, had become increasingly difficult to manage. She had mood swings. She snuck out at night. Joseph Kennedy wanted the problem solved. He authorized the procedure without, according to later accounts, telling his wife Rose. Rosemary Kennedy never recovered. The lobotomy left her with the mental capacity of a 2-year-old. She was incontinent. She could not speak more than a few intelligible words. She had been, by all accounts, a young woman who could read, write, dance, and attend social functions. She spent the next 64 years institutionalized. She died in 2005. Her family concealed what had happened to her for over 20 years. Here is the part of this story that matters most. Walter Freeman was not working in secret. He was not a rogue practitioner operating in the shadows. He was celebrated. His papers were published in peer-reviewed journals. He lectured at conferences. The American Medical Association gave him platforms. State hospital systems invited him and paid him. He was profiled in newspapers as a pioneer. And the Nobel Prize in Physiology or Medicine in 1949 went to Egas Moniz, the Portuguese neurologist who invented the original procedure. That prize functioned as a legitimacy stamp on every lobotomy Freeman ever performed. The outcomes that made Freeman's reputation were not medical outcomes in any rigorous sense. They were social outcomes. Overcrowded state psychiatric institutions were in crisis. Wards were understaffed. Patients were physically difficult, violent, loud, unmanageable in the absence of effective pharmacological treatment. The lobotomy produced compliant patients, quiet patients, patients who sat still and didn't trouble the staff. Families brought in someone unmanageable and were handed back someone who smiled blankly and needed to be fed. Many of them called this a success. Some of them meant it. Behavioral scientists have a name for what was happening in these rooms. Outcome bias, judging the quality of a decision by its outcome rather than the quality of the reasoning that produced it. If the patient was quieter, the procedure worked. The reasoning didn't need to be examined. Alongside this ran authority bias, the tendency to trust and defer to figures with institutional credentials, even when the specific credential doesn't match the specific act. Freeman had a medical degree. He wore a white coat. He published papers. That was enough. The specific question, is this man qualified to perform this surgery, was never seriously asked at the institutional level, because the institutions didn't want to ask it. The instrument he used was not a scalpel. It was an ice pick. The kind you'd find in any kitchen drawer. Walter Freeman modified it. He called the modified version an orbitoclast, a more medical word for a more medical purpose. The purpose was the same. He would lift the eyelid, insert the instrument above the eyeball, into the orbital socket, and then, using a mallet, drive it through the thin bone, into the frontal lobe. The whole procedure took 10 minutes, sometimes less. Freeman did not operate in operating rooms. He had no surgical training. He was a neurologist, a man who studied the brain but was not licensed to cut it. He traveled, state to state, institution to institution. He called it the lobotomy tour. Between 1936 and 1967, Walter Freeman performed, or supervised, approximately 3,500 red lobotomies across 23 red states, on patients ranging in age from 4 years old to the elderly. Not all of them survived. Many of those who did were left unable to care for themselves. Freeman considered this acceptable. Freeman believed, and this is important, he genuinely believed that he was helping. That the mental institutions of mid-century America were so overcrowded, so under-resourced, so brutal in their own right, that a 10-minute procedure that sent a patient home was, in his view, a mercy. The patients he sent home were often calmer, more manageable, quieter. Whether that constituted healing depended entirely on what you thought a human mind was for. Walter Freeman didn't call it surgery. He called it a procedure. The instruments were simple: an ice pick, a mallet, sometimes a standard medical leucotome, a thin metal rod with a wire loop at the end. He would insert the pick above the eye socket, drive it through the orbital plate, the thin bone at the top of the eye socket, and into the frontal lobe. Then he would sweep it, side to side. The operation took 10 minutes, sometimes less. Freeman believed the surgery worked by severing the connections between the frontal lobe and the thalamus. He believed it interrupted the feedback loop of emotional distress, that it gave patients peace. What it actually did, in many cases, was remove the person. Patients who had been agitated, distressed, violent, they became calm, compliant, quiet. To their families, to the institutions housing them, this looked like a cure. It was not a cure. It was a subtraction. By 1951, Freeman had performed the transorbital lobotomy on more than 228 patients in a single year, traveling state to state in a van he called the Lobotomobile. He was not operating on illness. He was operating on behavior. And the difference between those two things is the difference between medicine and control. By 1946, Walter Freeman had refined the procedure. He no longer needed an operating room. He no longer needed a surgeon. He no longer, really, needed much of anything. The transorbital lobotomy, his version, the version he invented, took 10 minutes, sometimes less. An ice pick, inserted beneath the eyelid, tapped through the orbital bone with a mallet, swept left and right to sever the connections between the frontal lobe and the rest of the brain. No anesthesia required beyond an electroconvulsive shock to render the patient still. Freeman believed, genuinely believed, that speed was part of the point. That if lobotomies could be done quickly, cheaply, and without a surgical theater, then they could be done everywhere. In state hospitals, in clinics, in offices. Anywhere there was a patient and a willing physician. So he bought a van, had it converted, loaded it with equipment and patient files, and drove across America. He called it the Red Lobotomobile, Red. Between Red 1946, Red, and Red 1967, Red, Freeman performed or supervised lobotomies in Red 23 Red states. He drove thousands of miles. He took photographs. He kept meticulous records. He was proud of the work. In West Virginia, he operated on Red 228 Red patients over the course of Red 12 days, Red. Some were children. The youngest was Red 4 years old, Red. The medical establishment did not, for the most part, intervene. The American Journal of Psychiatry ran favorable reviews. Hospital administrators wrote to him, asked him to come. Freeman was not operating outside the system. He was the system. Or rather, the system was him. A mirror held up to what American psychiatry chose to become. Freeman kept records, meticulous ones. He tracked his patients the way a scientist tracks an experiment: names, dates, diagnoses, outcomes. What the record showed, what Freeman himself published, was that a significant number of his patients became calmer, more manageable, easier to care for. What the records also showed, if you read them carefully, was something else. Patients who had been musicians stopped playing. Patients who had been artists stopped making art. Patients who had been difficult, and by difficult, institutions meant inconvenient, became quiet. Freeman called this a success. He would write to the families of patients, often in cheerful, almost promotional language, describing how their mother, their brother, their wife was now cooperative, was now no trouble at all. Some patients recovered. That is true. Some went home, some held jobs, some, by any external measure, functioned. Freeman pointed to them. He pointed to them often. But the follow-up was inconsistent. Freeman tracked outcomes he wanted to track. The patients who deteriorated, who lost language, initiative, personality, moved through institutions that did not always report back. Or they moved back home, into the quiet of private failure. By the 1950s, Freeman had begun to face resistance. Not from the public largely didn't know. Not from the government, oversight of psychiatric practice was minimal at best. The resistance came from inside medicine itself, from surgeons, from neurologists, from psychiatrists who had watched Freeman's patients and were not convinced that what they were seeing was healing. The invention of chlorpromazine in 1952, the first antipsychotic drug, began to change what was possible. If a chemical compound could quiet the symptoms of psychosis without destroying the person who had them, then the justification for the ice pick became very difficult to maintain. Freeman continued anyway. Through the 1950s, into the 1960s, he performed his last known lobotomy in 1967. The patient died from a cerebral hemorrhage. It was, for Freeman, the end. Walter Freeman was stripped of his hospital privileges. He spent the rest of his life defending what he had done. He never expressed regret. He believed, until the end, that he had helped people, that the math made sense, that the suffering he had ended outweighed the suffering he had caused.